Hello, everybody. Welcome again here in Antwerp, where we are together with Joe Gibson. Welcome, Joe.
Well, thank you so much. It's lovely to be here.
Thank you for joining us here today and tomorrow and the day after tomorrow.
Yeah. I'm very excited. Yeah, it's great to be here finally after all the COVID not being able to get here. It's great.
For all you listeners and viewers, we have Joe Gibson as our guest here in Antwerp with SmartEducation for her renowned course, The Shoulder Steps to Success. And we were happy and very fortunate to have her here already a day in advance so that we could do this interview for our podcast and on our YouTube channel. So let's talk a little bit about the shoulder, Joe. First of all, if necessary, and don't know if it's so necessary, but let me ask you, can you briefly introduce yourself?
Yeah, for sure. My name is Joe Gibson and I have worked as a upper limb specialist since 1995. That's when I got my job, just specialising in treating patients with shoulder pain or instability. And I also work in private practice. I've just started a new job actually at a performance centre, which is good fun. But yeah, I was just very lucky early on to get a job that with somebody that had a real vision for setting up a unit that was physios and surgeons working together. And really that's been my passion since 1995, making that work. And now it's a big unit with lots of amazing people. But private practice allows me to kind of maybe do more of the sports stuff. And so when I'm teaching, I always kind of really believe I need to be treating a spectrum of patients that reflects what everybody on the course is doing. So I feel very lucky that I have a foot in both those worlds, but that's kind of what I do.
Yeah. And you're based in Liverpool, correct?
Yeah, I am. Yeah, I've been
born and raised?
No, not at all. No, I was born in London originally. So I don't have a Scouse accent, even though some people seem to think I have. But yeah, no, I went to Liverpool basically because of my husband. So we met while I was at university in Manchester, went to Nottingham to do my first job, which is where I met Simon, who ended up coming to Liverpool, the consultant. But then, yes, we went to Liverpool because Nottingham was a good start, but it was never where I was going to finish. And then I got a job in Liverpool, much to my parents' horror, because it didn't have a very good reputation at the time, but it had a great orthopedic reputation. So yeah, so
enjoying living there, enjoying working
there. Love
it.
Yeah, love it. I actually live slightly outside Liverpool by the sea in a place called the Wirral, but having the city of Liverpool and a great football team and the great unit that I work at, no, it's great. It's a fabulous place to be.
But you've visited a lot of cities and countries around the world, haven't you?
Yeah.
Is it your first time in Belgium?
Not my first time in Belgium. I've been to Ghent before because Anne Cools, I'm delighted to say, is a very good friend of mine. So I've been to visit her and done conferences with her and taught the course in Ghent. But yeah, my first time in Antwerp for sure. Yeah.
And enjoying it?
Yeah, definitely. So I've been very well looked after so far. It's been fabulous.
But let's talk a little bit about the shoulder. The title of your course is The Shoulder Steps to Success. How many steps are there?
So I guess the course has resulted because I know when I started my career, I hated treating the shoulder. I thought it was the most complicated joint ever. I went on course after course after course, trying to work out what the muscle system was doing and stood watching this person move their arms and the expert at the front of the room saying, oh, you can see this working and that working and kind of nodding and not seeing anything at all. And then I was very lucky to spend time working with people all over the world and going on fellowships and doing all the courses myself. And so I guess when I was asked to teach, because I never really set out to do it, I was asked to do it because of the job I was doing. I just wanted to really simplify it and look at the key things that I thought had given me the most success. So I guess when I look at the steps, they're just some fundamental things in terms of the relationships with our patients, the very biopsychosocial perspective that we're told to take and the skills that are inherent to that. But then to me, the very simple steps of how I approached not only my subjective, but my objective, that importantly immediately tells you where to start with your treatment. So the whole aim of the course is to kind of empower clinicians to make sense of the madness of the evidence at the moment into simple steps that might guide where your treatment goes. So in terms of how many steps, there's probably 6 or 7, but you don't need to go through all of them. There's some fundamental things that set you up.
The shoulder is, of course, a joint that many of us treat. I think maybe every physiotherapist in private practice is seeing shoulder patients. In your experience and in your perspective from seeing so many physiotherapists around the world, what do you think which pathology is most difficult to treat and to use the most recent clinical guidelines?
Gosh, that's a really interesting question. In terms of what's the most difficult, probably instability, because people don't see it as much, atraumatic instability. I think that's probably the one that gives people the most headaches. But I guess what my research and that of others that's emerging has told us, it's very like any other shoulder pain. It's a lot of the time when things don't go well, it's more within that psychosocial domain than anything we're doing wrong as a clinician. But I think patients with instability, they need longer than our straightforward shoulder pain. And also that it's a time when perhaps we do need to do some slightly different things and target proprioception a little bit more specifically to get the best outcomes. However, simple things still work. It's just knowing what those simple things are.
Is that also a key to success, Joe? Keep it simple?
Oh, absolutely. Yeah, for sure. And I think I can't remember who did it, whether it was Einstein or somebody did some fabulous quote about you've got to understand it well to be able to teach things Einstein, in a simple way. Yeah. And he said it much better, clearly. But I think for me, I feel very lucky that there's no doubt I made it very complicated in the past. And I had this great belief in individual muscles and their importance. But actually knowing how I feel now, I want other people to feel like that, because there are simple things done well for long enough that will give you good results in the majority of your patients, as long as you get your communication right from the outset. So yeah, I genuinely think we can keep it simple. And actually that's really important for patients, because I think part of my job in the NHS is seeing patients that have failed. So they've seen 7-8 different physiotherapists. And often where it's gone wrong is overcomplicated explanations, a very structural model of things being wrong or out of place, or that's what the patient's heard. And so actually we know a lot of that isn't well supported now. And so it's kind of, let's just get your muscle system doing its job differently, better, keeping it simple for the patient, but also for us, having really simple things that we can do in our assessment that immediately become an exercise if they work.
I wanted to ask another question, but since you're talking about assessment, let me ask that question first. How important is a good assessment? And in your experience, how long do we need time with a patient to do a good assessment? Because here in Belgium, we only have half an hour for a treatment session.
Okay.
How does that work in your practice? And how much time is spent on the first consultation to get the assessment right?
So in my NHS practice, I have half an hour as well. But I'm very lucky in that if it's a complex patient, as in they failed with lots of other patients, I can have an hour. But generally, a first-time patient would be half an hour. In my private practice, I have an hour. And that was part of my contract. I stipulated that I wanted to have that. I think what's most important the first time you meet somebody is that subjective assessment, because particularly if somebody has issues within that biopsychosocial domain, if you don't pick those up and you don't address those the first time, they're a barrier. But sometimes if you've only got half an hour, we need to signpost that and say, look, this is all really important, but I think today I need to listen to this, and then look at your shoulder the next time. And when you consider that 80% of our decision making is based on that subjective assessment, it kind of doesn't make sense not to invest in that whole story. In terms of my objective, I think it's really important, because if you look at research, patients who haven't been looked at or examined feel like they're shortchanged. So the evidence might say, just look at a movement, make sure they're not stiff, see what happens if you move the neck, does it change their pain, and do some resisted tests, and that's enough. From informing your treatment, there's probably some truth in that, but from a patient, often that leaves them feeling, you haven't looked at me properly, you haven't taken it seriously. Now, I'm not saying we should do things just to make the patient happy, but my approach to assessment is kind of look at what matters to them, make sure they're not stiff, and then just look at some very simple tests of the cuff and the neck and thorax if it's relevant. But again, those things then translate into exercise, so the patient sees that what you found in the assessment immediately relates to what they're worried about, but also what they're going to do at home. So yeah, I think a thorough assessment is part of building that therapeutic alliance as well.
When you've done that assessment, we need to write down in our files what's happening with that patient and send a report to the general practitioner, for example. And then the following question is, where are you and in the debate on terminology? Because there's a lot of fuss about that as well.
There is a lot of fuss about that. And I was talking to you before about doing an interview about what we should call it. And certainly when we look at what's out there at the moment, you know, Jeremy Lewis has been a massive ambassador for our profession. And the whole point of his suggested term, rotator cuff related shoulder pain, was basically to say, look, that impingement model is out of the window. It's not well supported. We need a different language. The problem is that if you've done lots of shoulder courses, you're aware of that, but there's still people saying cuff tendinopathy, subacromial pain syndrome, then some very generic terms. The problem is there's a patient at the middle of this. So I guess my politician's answer is, my first starting point is what the patient's been told before. And if they've been told they've got, for example, impingement, my next question is, what does that mean to you? Because if they say, well, I've been told, my doctor, who I really like, has told me I've got impingement and says physio will get it better, why would I change that narrative? Whereas if they tell me I've been told I've got impingement, what does that mean to you? I've got a bit of bone that needs chopping off.
And then you change that idea.
Exactly. And
so you're not afraid to use the I word.
I'm not. I'm absolutely not afraid to use it if the patient's been told it before, but my job is to contextualize and educate in a positive way. And I can educate through my symptom modification, or I can educate through my words. I can do a mixture of both. But, you know, again, I think it's important to prepare patients for what they might see on the internet. So if they go on the internet and put shoulder pain, they're going to see the I word all over the place, and they're going to see rotator cuff tear. So I might say, look, we use a broad term like subacromial pain, but it includes all these things. The good news is it doesn't change how we treat it. It might influence how long it takes if it's a degenerative tear as opposed to a first-time shoulder pain, but the fundamentals of what we do are very similar. So yeah, I guess prepare the patient for what to expect, but I don't mind the I word if it's got a positive narrative attached to it.
Okay, and then about treatment, Joe. We know, and we've published this through our network, that you made a very interesting shoulder rehabilitation ebook. I have to say it's massively interesting, and a lot of people still are using it. Even if people here listening and looking at this episode, send us an email, I would say, and info@smarteducation.be, and we'll be sending you that ebook. It's perfect. It's available. It's out there. So yeah. A lot of exercises. How difficult is it to choose the right one for that patient on that spot of that time of the rehabilitation?
Not hard at all. So I think the important thing to say is the book was,
I knew that.
So the book was very much designed around post-operative care. So one of the big things that if you work in a shoulder unit and you've got a close relationship with the surgeon, you're very confident what you can and can't do and what's safe and what's not. And really this was a team thing with a surgeon and a group of physios, and it was, how can we make clinicians confident? And so surgeons were very happy with the EMG model. Now I know we could argue about that, but you know, it was something they were happy with. And so the book really was a summary of all the EMG research and how you could say early, middle, late in perhaps somebody'd had a rotator cuff tear. So that's probably why there's such a lot, because it takes you from the start to the finish. But if I'm seeing somebody, whilst a lot of the exercise in the book is things that I use in my practice, the bottom line is I do an improvement test. If I change it, that informs my exercise. But essentially, there will always be no more than 2 or 3 things that are common to every patient. The only difference is their painful movement. So whether it's this, whether it's rotation, what is the thing that matters most to them? So whilst there's lots of different ways of achieving it, the way I teach the course is, this is how you start with in how you find where to start, and then it's easy to know how to progress because of what you've assessed and how it changes.
Okay. About the course again, you've been teaching it for, what was it, 20 years?
At least, yeah.
I was wondering, what was in that whole evolution, what was the biggest change in that you thought, now I'm going to need to change my course completely? What helped you, and what kind of insights that you had made a big difference and changed the course a bit? And was it recently? So actually, I'm asking you about how is the evidence now, and is it going rapidly?
That's a really interesting question, because I think the course evolves all the time. Every time I teach, I'm reading papers in the weeks before and in between and making sure I'm keeping current. But when I look at the actuals of what I do, the approach I've used in terms of symptom modification and my understanding of the cuff, probably I've taught for 10 or 15 years, but I guess the bias and how I explain it has changed. I guess that's the thing, is that when research comes out challenging specific exercise, just do something for the shoulder, or as we absolutely understand the psychosocial, the lifestyle factors, shining a light on all those things. But I still think for clinicians, it's really important to have a structure from that objective, because if you're a confident clinician, you convey that to your patients. And so saying just do anything can be quite hard, I think, particularly if you don't treat a lot of one thing. Whereas if I can say, well, actually have these ingredients, which when I look back, I've probably, in terms of what I actually do, that hasn't changed a lot in the last certainly 10 years, but how I explain it has. But when I look at something like frozen shoulder, the way I teach that now, completely different. What else? Let me just think. So I guess it's an evolution all the time that reflects my evolution as a clinician. But I think I would have to say that Jeremy's been very influential in terms of how he's challenged the evidence. But I also think working with orthopedic surgeons and seeing their massive bias, as well as working with some amazing clinicians, I think allows you to keep it real and recognize the challenges other people have got. You've been involved in research yourself. Are you also aware of what's in the pipeline? What the research is focusing on now? So there's a massive shift towards looking at lifestyle factors and looking at that communication domain. But in the UK particularly, that lifestyle domain is a real topic of focus at the moment, in terms of actually there's been a couple of studies that have shown the people that didn't do so well, who still had high levels of pain after an intervention, were overweight, smoked, although didn't exercise regularly. So there's a couple of studies that are going to be looking at doing a lifestyle intervention versus doing physiotherapy and seeing if that has a better outcome. But then on the other side, a very physiotherapy thing, there's certainly some more research emerging looking at things like graded motor imagery and mirror therapy, specifically in things like frozen shoulder and some nerve injuries around the upper quadrant. So yeah, there's some quite diverse things going on at the moment. Jeremy's got a paper coming out soon, which he still won't tell me the results about, which is looking at true strengthening versus a symptom modification approach. So that'll be very interesting when that finally comes into the domain. So yeah, I think there is some emerging research maybe challenging some of our approaches to exercise as well, but I think that's a watch this space. And I'm guessing it's already being implemented a little bit in the course, the lifestyle factors. Oh, for sure. We're talk about that in the next couple of days. Yeah, for sure. I think I always start the course setting the scene with the current challenges that there are for us as clinicians and all the things that we used to. Certainly when I first taught my course, it was special tests and muscles working at different parts in range, and that's just not well supported now. So I kind of acknowledge that and exactly where the evidence is going. But ultimately, it's also you've got a patient in front of you. They don't want to be told to lose weight or give up smoking. They've come with a shoulder problem. So how do we build up that relationship? And then if it's relevant, address those things as part of our treatment. Yeah, perfect. And I have to say, it keeps it always interesting. I think I can speak for everybody here listening, and for myself, of course, that over the 20 years that we've been treating our patients, a lot has changed for the better, of course. And if I hear you talking, I think a lot of it will even change in the future as well. Yeah. So we'll watch this space, your space. I would invite everybody to have the opportunity to be present at a course with Joe. Of course, for tomorrow and for the day after tomorrow, you won't be able to visit us, but next year. Yeah, absolutely. Yeah, Joe is coming back next year. So please come and join us. We will welcome you with open arms. For now, let's wrap this up, Joe, because we're going to have dinner together. We're going to do some sightseeing in Antwerp. Fantastic. And
take you early to bed, maybe, that the course will be...
So I'm ready for action.
Yeah.
Absolutely.
Thank you for spending your time here with us. And all the best for tomorrow and then the day after tomorrow.
Thank you so much. Thank you so much for inviting me. I love what you're doing as a company, and it's just great to be involved. So thank you so much.
Thank you. Okay. And thank you for everybody here listening. Please give us a like, join our YouTube channel, or put our podcast on listen to our podcast episodes on your favorite podcast channel. Okay. Thank you. See you later. Bye.
Bye.